everyone. Can everybody hear me okay? Yes. My name is Deborah. I am the social worker in the healthcare facility, and I am filling in for Suzanne this morning. She's not here. We wanted to present to you Jade and Taylor from Heart to Heart Hospice. So Jade is going to come in and give you some information about hospice and everything that she can think of about hospice and the services they provide and all of the details. And then once she's done with the information, you will have the opportunity to ask her any questions that you might have. Okay, here you go, Jade.
Good morning. Good morning. I wanted to touch a little bit with everyone on hospice and the services we provide. There's a lot of misconceptions about hospice and what qualifies somebody for hospice. It used to be when someone went on hospice, it meant they were dying in the next several days. It's not like that anymore. Hospice provides so many different services, and we've had several patients that have been on service for years. You know, it's not just a day thing anymore. We provide care wherever you are, whether it is at home, in a facility, anywhere that you live. We've provided care for people that are living out of a hotel, out of Haven for Hope. Anyone can get hospice no matter where they are. Our goal is to care for someone and allow them to pass where they want to, whether it be in a hospital or at home. We want you to pass where you're comfortable. We want you to be comfortable for whatever time you have left. One of the things with hospice, a lot of people think that you have to have a DNR. A DNR is a do not resuscitate form. Everybody, I'm sure here, has an advance directive, but a DNR is actually a separate form from that. It's not mandatory for somebody to come on hospice. It's not mandatory for them to have a DNR. A lot of the patients we have are a full code when they initially come on, and maybe a few months down the line they decide, I want a DNR. So that if a patient's heart stops, we won't do anything to restart it. Now, if someone is a full code, meaning they do not have a DNR, and we are there when their heart stops, we will do everything in our power to restart it. We also work with a program called MIH. It means Mobile Integrated Health. So if a patient, for whatever reason, calls 911, the fire department always shows up when you call 911. We work with the fire department. Each of our patients are flagged in their system so that if they show up here, they will do everything they need to stabilize the patient until we get there. Whether that means IV fluids, IV medication, anything they need to stabilize them so that they don't have to go to the hospital. A lot of our patients don't like going to the hospital because they know if they go in, they may not come out, or it may be a while before they come out. Hospitals are a great place for starting a healing process, but it's not the type of place you want to complete it. People initially when they go into the hospital feel horrible, and they're in there for numerous reasons, whether it be a heart attack or a stroke or complications with their cancer. You can go and start to heal there, but people always heal faster when they're in their own environment instead of just the sterile four walls of a hospital room. So with MIH, you can stay where you are, and they will do everything to make you comfortable. And a lot of times that means they might have to give IV morphine or IV fluids. A lot of people think you can't get IV fluids if you're on hospice because it used to be we don't do anything invasive, and to a point that is still true. We don't do anything invasive. IV fluids is invasive because you have to have, an IV put into your arm. So we didn't used to be able to do that, but now they see that as a comfort. So if a patient actually needs the fluids just to make them a little more comfortable, then we'll do that. If a patient gets an infection, no matter what type of infection it is, it could be a respiratory infection, a urinary tract infection, we treat those. Our hospice gives antibiotics. Now, sometimes somebody may not react to certain different antibiotics, so we might need to change it several times. If a patient isn't able to swallow pills, or they aspirate on liquid medication, we can do a Rocephin injection. It hurts. Anyone in the military knows what a peanut butter shot is, right? Okay, so it is a shot so I have 3 sons in the Marine Corps. And when they first went in, they all got these shots that they call peanut butter shots. And it is painful. It's very thick, so it hurts. That's what Rocephin is. That's why that is our last line of defense when it comes to an infection. It's an uncomfortable shot, so we try not to do Rocephin injections, but it doesn't mean that we can't do them. Okay? What is another thing that I can go over? What comes with hospice is you get your nurse. A nurse will do visits according to how often the doctor feels you need to be seen. So if someone, when they first come on, is having a lot of issues, they're having a lot of respiratory distress, or we're trying to get their pain under control, then the nurse will have to come out daily. If they are doing good and we're just maintaining their comfort, you may see the nurse twice that week. We also do CNAs. CNAs come out to do the things that you can't do for yourself, whether it be showers or bed baths, getting you dressed, getting you up in your wheelchair. They will do all those things. Let me get a drink. I'm sorry. Oh, perfect. Sorry. So the CNAs will do all the things for you that you can't do for yourself. You also get a social worker. Now there's a social.
Microphone.
Oh, sorry. You'll also get a social worker. You guys have a social worker here at the ARC, but with your team with hospice, you get another social worker. You also get a chaplain. Now you can decline any of the visits. We can't force you to see the chaplain or the social worker or the CNA. So you can decline the things that you don't want. It's kind of like a menu. You pick the things you want to use. Any equipment that you need, durable medical equipment like a bed, a shower chair, the Cadillac walkers, which I see some of you have, the ones with the little seat, we can order those things. What happens is everything is 100% covered by Medicare. We pay into Medicare forever, and this is when we finally really get to utilize it. Medicare pays 100% of hospice. Okay, so there's no bill for hospice. And then when they pay us, hospice pays for things like the medications that pertain to your diagnosis and anything for comfort. They pay for the equipment that you need and all the different visits that you need. Okay? You also don't have to stop seeing your doctors. People think that when they come on hospice that you can no longer see your primary care physician. Not true at all. You actually get to choose your physician. Now, if you want to keep your primary doctor, we will absolutely reach out to the doctor. The only problem that we run into sometimes is our hospice doctors are used to getting a call at 4 in the morning or 2 in the morning because we've received a phone call that someone's having a pain crisis. If we go out at 3 o'clock or whatever in the morning and someone is having a pain crisis, we may need to order a medication right away for it to be delivered. If we order it at 2, it is there in a couple of hours. Okay, so we need a doctor to sign off on those things. So sometimes the doctor that you choose, if it's your primary care physician, they don't want to do those phone calls. So a lot of times people will just revert to our physician. Now, if your doctor says, I absolutely want to follow, but can you use your hospice doctor for the 2 in the morning phone calls? We can do that too. Like I said, hospice is kind of like a menu. You get to pick the things that you want. Okay? The chaplain, let me tell you what each of the disciplines does. So the nurse, of course, she'll come out and assess everything medically. She'll do a full body assessment. If somebody has wounds, they'll treat the wounds because that's comfort. If we think that they might have an infection, we order antibiotics for that. If they're having problems with their blood pressure, if a patient was on a medication when they come on hospice, such as blood pressure medicine or Lasix because they've got a lot of swelling, if it is still working for them, they don't come off of it. Now, if they're on a medication that doesn't pertain to the diagnosis, we can still give you a prescription for it. It'll just get paid through your TRICARE or your Medicare. It won't be something that hospice pays for. Okay, so we can do things like that. If, the nurse comes out and she says that no matter what we're trying, we can't get the pain under control, because we have the ability to switch medications every day. We can do a fentanyl patch, we can do morphine. We usually start with the small things though. If Tylenol works, great, we don't have to go straight to morphine. If someone is like 800 milligrams of ibuprofen and I can take a jog, then do that. We start small and work our way up. But if someone's in a pain crisis and no matter what we're doing, it's not resolving, then we do what we call crisis care. Crisis care means that a nurse would come out and they would do 12-hour shifts. I used to do crisis care a lot. So I would go and I would sit in the house or in the patient's room and I would medicate them the way the doctor tells me. So if he says, let's try giving them this every hour, then I would give the medication every hour. When someone's in a pain crisis, we have to chase the pain and then kind of get ahead of it. So initially, it almost seems like, wow, they're giving way too much medication. It would seem like that, but it's because we have to get ahead of the pain. But once we get ahead of it, then we can back down a little bit and just maintain their comfort level. Okay, so once the nurse gets them comfortable, then the crisis care would stop. But until they are comfortable, the nurse would be there 12 hours a day. So each shift, you would have a nurse 24 hours a day, but they would do 12-hour shifts. And we would do that until they are comfortable, or unfortunately until they pass. But our goal is for someone to pass without pain. So we'll do whatever we need to. I already told you what the CNA does. Okay, the CNA goes out and does the bed baths and everything, or the showers, gets you dressed. They can tidy up around, your room, do things like that. And then the social worker is there to help people with, I don't think it would so much be an issue here, but sometimes people don't have their funeral plans made, or they don't even know where to start. So the social worker is a good resource for that. So am I. I'm good at that part. So if they need to work on something like that, then they'll do it. If there's somebody that doesn't have their advanced directives or their DNR, they'll assist them with that. A DNR doesn't have to be notarized. All you need is a physician's signature, 2 witnesses that are not related by blood or marriage or have any financial gain in the event of someone's passing, and then the patient's signature or the patient's MPOA or wife or husband. That's it. And then we put it in the chart and it is effective. Now, if you were to sign a DNR today and in 2 days you say, you know what, I want to be a full code, I'd be like, okay, let's just take it out the chart and you put it away until you're ready to utilize it again. Nothing with hospice is set in stone. Even if you were to sign on to hospice today and decide tomorrow, you know what, I want to go ahead and pursue aggressive treatment, then we would stop it. You have an unlimited number of benefit periods with hospice, or with Medicare, sorry. So if you decide tomorrow, I don't want to do hospice anymore, then we'll have you sign a piece of paper saying that you want to revoke hospice, and that's it. It's done. And then in a week, if you decide, no, I want to try hospice again, then we would sign them back up again. I've had several patients here do that, and I'm okay with that. I've got a lot of patients in the building, so I'm here quite frequently. A lot of people have stopped me in the hallway to ask a little bit about hospice. If you see me and you've got a question, just stop me, because I'm here several times a week, just scooting around. But like I said, nothing is set in stone. A lot of people think that because they sign consents, it's a contract. It's not a contract. Really, all the consents is, it states that you're allowing us to bill Medicare and that we're admitting the patient to wherever they are, whether it be at home or in healthcare. Okay? So don't be afraid of the consents. It's not a contract. It's just saying that we can bill Medicare. Okay? Let's see. The chaplain. The chaplain is there for spiritual support. If you don't want the chaplain, you don't have to have them. If the chaplain comes out and you say, you know what, I'd really like a priest to come out and give sacrament of the sick to my loved one or to me, then he sets that up with a priest. They can do anything that you need spiritually. If someone's Buddhist and they want a Buddhist monk to come out here and pray with them, then the chaplain would set that up. Okay, we do it a lot. There's a lot of people that have, different religions, so the chaplain is there for that part. Now, our medical director. I've been with Heart to Heart for 6 years. Our medical directors are phenomenal. I'm very, very fortunate enough to work with some amazing doctors. And the doctors are actually mine, my husband's, even my daughter's doctors now. We have a nephrologist, Dr. Jeet Gandhi. We have Dr. Ishmael Sosa. He's the gerontologist. We have Edward Lizaga. We have Dr. Chalasani. We have Dr. Juan Park. He's a new one. You know him? He's amazing. I call him the last airbender because that's what he looks like. But we have really, really great doctors. The doctors are always on standby for us. Okay, so if we call them and say, look, this is what's going on with the patient, what do you want us to do? They can go ahead and sign the script, and it's all electronic, so it's faster. They sign a script, that medication gets delivered to your front door or to the facility. If you're in healthcare, it'll come straight to the facility and it's there. Okay? So you would have a Monday through Friday case manager. The case manager is your primary nurse. She's the one that you would see the most. But you also have Monday through Friday night staff. It's always the same staff. We don't contract out our nurses. We have core staff for each shift. So if you get, call at 2 o'clock in the morning with something, then you'll always see that nurse come out. If you call on the weekends, we have weekend staff. We are available 24/7. I always like working Christmas and Thanksgiving. I have for 6 years now. So if you call and it's Thanksgiving and you're like, Jade, so-and-so fell, or I'm just not feeling good, I'm having a lot of pain, I'm like, okay, for me, I'd say I'll be there in 15 minutes because I'm right up the road. So we work nights, weekends, holidays, we're always available to you. Even if it's just a question. Sometimes I'll get a call saying, my wife is still in pain. Is it okay if I give her a little extra morphine? Or my wife is short of breath. Can I give her a little extra morphine? I'll say absolutely and tell them how much to give. So sometimes it's just nice being able to call someone. Okay? What else? Hospital visits. So a patient, if they choose to go to the hospital because they've fallen, right? Sometimes someone will fall, they might fracture something, or they might need stitches. They can absolutely go to the hospital. And we'll communicate with the hospital. So I work with BAMC, which is where a lot of the residents here end up, and Northeast Methodist, which is where another handful always end up. If you go to the hospital, I'll go to the hospital. I'll find out what you're going to be there for. If they're going to admit you for something that doesn't pertain to your diagnosis, so if you're on for cardiac disease, or because you've had a stroke, more cardiac disease, and you fell and they think that you've broken a leg or you've broken a hip, that doesn't necessarily pertain to the diagnosis, so you wouldn't have to come off. Now, if someone's on for dementia and they've fallen, those two are pretty closely connected. So all we would do is sign that little revocation form while you're in the hospital, and when you come home, we'll sign you back on again. We do that so that Medicare pays for the hospital. Medicare won't pay for both. It's either or. We never want anyone to get stuck with a hospital bill. They can be pretty big. So we'll sign you off when you're in there and then sign you back on when you come out. Sometimes people go several times. If you keep choosing to go and then you keep wanting to come back on hospice, then we'll keep signing you back on hospice. Like I said, there's an unlimited number of benefit periods, but we always try to keep somebody where they are. If somebody needs lab work for whatever reason, then we'll come out and draw their blood and drop it off at the lab. If someone has fallen and needs an x-ray, we have a mobile x-ray company that will come out and x-ray you in your living room or in your bedroom. Anything that goes on apart from stitches or resetting someone's hip, it's off. Other than stitches or doing surgery on someone's hip, we can do everything where you are. So like I said, our goal is to keep you here. If somebody, I don't know, says, my wife is, like if you're living in the independent cottages or in the houses, and they say, my wife really, she's not doing that well, it's really hard to take care of her at home, or the wife says that about the husband, and they say, we may need to think about a facility, then that's where we would pull Deborah and Suzanne in to say, hey, this patient might need to go into healthcare, and we'll follow them. No matter where you go, you could go to the moon and we will follow you to the moon to make sure you get your visits, okay? So no matter where you go, we will be there for you. And I always give everyone my cell phone number. Mr. Hilton has my number. Everyone has my number. So if anybody needs me, just reach out to me. I give it out so that people use it, because sometimes it's just a question. You may have a question about hospice. I want to be able to answer that for you. Hospice is a really big decision to make. It's, like I said, it's not a contract, but it's still a very big decision. When somebody chooses to allow us to take care of their loved one, it's almost like someone inviting us to be at a birth, only it's the end of the life, right? It's a very special moment. There's no do-overs in death. We want everything to be perfect, okay? Because like I said, there's no do-overs. That's why it's a big decision. Now, I know I'm with Heart to Heart Hospice, but there's 302 different hospices in San Antonio. If there is one that you prefer over Heart to Heart, that is your right. It's your decision on what hospice you go with. Now, I know that the ARC has contracts with certain hospices. If you choose one that they don't necessarily have a contract with, then Deborah can work out a one-time contract so that they can come in just for you or for your loved one. Because nobody can force you to go with a certain hospice, okay? We want you to go with who you want to. I just happen to be the one that's in here a lot. I've got a lot of patients in here, but I've been doing this 24 years. I literally grew up in hospice. All the women in my family, I was just telling Deborah, my cousins, my aunts, my grandmother, all of us are hospice nurses. When I was growing up, my grandparents owned 2 facilities like this in California, and I grew up running around the hallways. The hospice nurses that came into the building I was in the most were actually nuns. And I always called the residents my friends. So I would be on the edge of the bed going, what are you doing to my friend? And they were kind enough to explain it to me. So when I was growing up, you know, people are like, oh, I want to be a doctor. I want to be an astronaut. I want to be this. I said, I want to be a hospice nurse. And so that's exactly what I did. After I graduated high school, that's exactly what I went into. And I've been doing it ever since. And I love hospice. In order to do this job, you have to love it. Trust me, I cry daily. I really do. But I do it in my car. But I do cry every day, but I still would never trade this job for anything because I get to see what it does for the patient's family. Hospice is just as much for the family as it is for the patient. And after a patient passes, their family still has our services for 13 months. The reason for that is first birthdays, Mother's Days, Father's Days. Like this Father's Day is going to be without my dad. We want to be there for those things. We want to be able to hold your hand and comfort you and get you through all those firsts. So you have us for 13 months so that we can kind of get you over the hump. And if you need us longer than that, then you call me, because I still keep in contact with family members that, you know, of people that passed 12 years ago. I love that. So we are here. No matter how long you need us for, just call me. If you're having a bad day and you're like, Jade, I just need you to come over, don't talk, just hold my hand, then Jade will be there just to hold your hand. Okay, so hospice is for the loved ones also. Yes, the patients get more hands-on, but emotionally and for the support, it's for the family. Okay? Does anyone have any questions?
With the very comprehensive services you provide, do you have a limited number of people that you can handle, so that if tomorrow I need it and call and you say, I'm sorry, our patient load is maxed out, you don't have a limit?
Nope, we do not have a limit. As we grow, the staff grows.
The second question is, where's the break point between, say, home health or nursing coming in just occasionally, not necessarily at the hospice level?
Mm-hmm.
How do you qualify for hospice? Do you have to have your family doctor, Medicare, nurse? What's the approval process to graduate from one to the other?
So in order to be, I always like to evaluate everyone. All we need is a physician's order. So your primary doctor would write an order saying hospice can evaluate and treat if appropriate. And then they would send us clinicals on, you know, any office visits, you know, like your last 4 or 5 office visits. And if you've been in the hospital, then we'll collect those clinicals. You have to have a terminal diagnosis. At the time of evaluation, it means that the doctors think without any care that you could pass in 6 months or less. But remember, I told you we've had patients that have been on service for a year, 2 years, 3 years. Patients, it is a fact that patients live longer on hospice than they would without us. The reason for that is the nurse coming out, if you get an infection, because we catch it right away, we treat it, right? If you didn't have hospice and you were just sitting at home and you had this cold, or you've got, you know, a really bad cough, that respiratory infection can turn into a pretty severe pneumonia. But now I know some patients are really stubborn. You will not go to the doctor until it's really dire. But with a nurse coming in, we catch those things right away, which is why we can extend someone's life by being there for them. We are there for however long they have left. We just make it comfortable. But to answer your question, we just need to see that This physician says yes without care that this patient could pass in 6 months or less. And if, for some reason, like we were to come out and evaluate you, and we say, well, you're not quite ready for hospice, then I would team up with Deborah so that we can get you set up on home health. And then when home health feels that, okay, they're ready for hospice, then I would step back in the picture. It's always good to have those things made ahead of time, so that if someone were to go into the hospital tomorrow that is here talking to me right now and all of a sudden they can't talk anymore, they can't make decisions, those decisions can be really hard for family. They always think shoulda, coulda, woulda, right? Do you think they'd be okay if I put them on hospice? Do you think they'd be okay with this hospice or this home health? If you have those decisions made ahead of time, I keep a book at my house, right? It's glittery book. Nobody in the house can miss it. But I had stage 3 cancer, and that's when I started the book, because I wanted my husband to be able to go to that book and not have to make all those difficult decisions. I didn't want him to have any doubts. It said, this is the hospice I want to go to. This is the home health. These are my wants. They're in your advanced directives, but I got very detailed. I'm like, yes, you can do this, but absolutely don't do this. I mean, even things down to music. Play this music for me, right? So having all of these plans made ahead of time can be very beneficial to you and your family, so that when you can't talk anymore, your words are there and they know what you want, and you don't kick yourself thinking, man, is he going to be mad that I put him on hospice and he passed away after a couple of weeks, which does happen. Not because of hospice, but because of whatever you had going on. Any other? Okay.
You hear the term hospice and you hear the term palliative care. Are they the same? And if not, what's the difference?
They're like brothers.
So there is a difference between hospice and palliative. Now with palliative, it means that you can get aggressive treatment if it's for comfort. So if somebody has cancer and they have this massive tumor growing, and the doctor says, look, if we do a little bit of radiation or a little bit of chemo, we can shrink the tumor so that it's not hurting so much. That is palliative. You can have hospice if you're getting palliative chemo or radiation, as long as it's 3 visits or less. Okay? It's a Medicare rule. It's not ours. So they have to have 3 visits or less. But palliative is where you can get aggressive treatment.
How often do palliative staff come versus hospice staff?
Not very often. So with palliative treatment, you don't get as many visits. You don't get all the bells and whistles. Same with home health. Yes, home health comes out, but they don't do as much as hospice. You get a lot more care with hospice. You get a bigger team with hospice. But palliative, you won't get as many visits. And a lot of time, people that are doing palliative, they actually go to the facility or to the cancer center or whatever themselves, or over to BAMC for their chemo. So that's your visit. But with hospice, you can get palliative care. It's a case-by-case basis, though. This is a very big room.
As a physician, and some of you know me already, some odds and ends. Number one, I have personal experience on 2 levels. Number one, I was a chair of the ethics committees for a hospital system here in town. That's a legal requirement in Texas, but also involved a great deal of end of life. For my own family, when my wife passed, we elected inpatient hospice. It matched the tempo of her illness, and it was marvelous. I will always be an advocate for hospice. Couple odds and ends, the people in this room represent a unique population, and I'm part of it. We are only maybe a generation and a half removed from end of life being the doctor hitching his horse to the buggy and by moonlight riding out to the house to provide laudanum. In my career, as it started, we did not have intensive care because we didn't have ventilators that were safe. So I have experienced this transfer to prolonging life. There is an alternative term that is used to DNR, and it's been advocated, and I'm not advocating, I'm just presenting it. It's allow natural death, AND. That provides just a little bit of a different perspective as to how we approach in the United States the end of life. The last item is your family, your family, your family. I have seen utter chaos descend when the doctors at the hospital are so afraid of not doing something that they do something that was really not wanted as the process actually unfolds. And they are afraid of Cousin Harry sending a telegram from prison that he wants his mom to be supported forever, and will respond to that one piece of information instead of other information that is available. When you have your family involved and they know your wishes, they will be your advocates. That's the solution to the chaos that I have seen personally in the people I have, the patients that I have dealt with. And that's your ultimate attaboy to get done.
While we're on the topic of family, while I walk over there, I also want to let everyone know I work really closely with the Red Cross. If any of you have grandchildren, for instance, that are in the service and they're deployed, and you let me know or your family lets me know, as it gets very close to your passing, if you say, I really want my grandson home or I really want my granddaughter home, I'll work with the Red Cross. I don't care how long it takes, and I will get that loved one home so that they can say goodbye to you, okay? I can take care of that for them. If your daughters or your sons need to leave work so that they can come be with you and take care of you for whatever time you have left, let me know so I can have the doctor sign their FMLA paperwork. We'll do all of that for you. Our doctors are really amazing in that way. We want you to have your family around if that's what you want. But if you need me to be a bouncer, I can do that too, okay? Because that does happen. So if there's family that you don't want around or you think is gonna make someone more agitated, say, Jade, I don't want them here, and I'm tougher than I look. I can do it. You had a question?
Yeah, I asked if you would please address the fact that people tend to wait too long to put their family member or themselves on hospice care until you're down to the last moments. They can do so much for you in those last 6-12 months you have to make your life much more comfortable and more meaningful. If you've got a terminal diagnosis, don't wait. Allow them to go on hospice care. That's just my.
You want to talk about your 11th hour? Oh, okay. Oh, okay. Yes.
It's not real, it's kind of a question, kind of an information thing. You mentioned the MIH, that EMS can come out when they're on hospice, provide fluids, okay? And they don't have to go to the hospital, and they're not charged, okay? If you have dementia, you're in a dementia care unit, and you go unresponsive because your blood sugar dropped too low, they called EMS, they came out, started the IV, responded, got the patient back to where they could eat. I did not want my husband to go to the ER, and San Antonio EMS sent him a bill because he did not go to the hospital.
Not with us.
No, he was not on hospice. He was not on, that's what I'm saying. What, you were talking about benefits, okay. He was not on hospice, but he was in dementia care, went unresponsive. If EMS had not come, he would have probably have died. So the EMS did exactly what they were supposed to do. They revived him. He was able then to eat. And because they did not take him to the hospital, then he was billed an EMS visit.
Yeah. It's sad that happens, but it does. Now, the way we work with MIH is for each of our patients, we pay for each of them to be part of this program. Remember, I told you Medicare pays us and then we pay for all the little things that come up. MIH is one of those things. For each patient that we have on service, we pay whatever the cost is for them to be part of the program. And we get billed. It's all for nothing. You don't get billed for anything that we do. If MIH comes out, hospice covers it. Okay? If you decide, say you come on for, a respiratory issue, COPD, and one day you say, Jade, I want to go see my pulmonologist. Now, Medicare would deny paying the pulmonologist because you were on service for COPD. But if you say, Jade, I want to go, we will call the pulmonologist ahead of time, tell them that you're on hospice so that they can bill us, so that we can cover that visit. As long as it's not going to be an everyday type of thing, you can go do it. Go see your doctor. Go see whatever doctors you want. Just make sure your nurse knows ahead of time so that you don't get a bill for it, so that we can call that doctor's office and give them the code to bill us. Okay?
You talked about your little glittery book with your wishes.
Yes.
How legal is that? Do you have to sign it? What?
I sign every page.
Okay,
Mm-hmm.
okay.
Yeah, thanks. It's a good book to have, and you can always get it notarized if you want to, but if your family knows about it, they're rarely going to try to fight it. They'll abide by those wishes. Okay? Yes.
So the cost again, if you're all alone, but you prefer to stay in your house, is the cost of 12-hour shifts round the clock part of it, or
Yes, it's all included with hospice. It is
with Medicare will pay for
Mhm.
if, instead of sending you to the healthcare or something?
right. But like I said, that is, the 12-hour shifts are just if there is something going on that isn't resolved by whatever we currently have you on, that is needing constant changing.
If the patient
Yeah.
is in crisis at
Mhm.
that moment, it's not a regular
Right.
hospice benefit.
Correct.
Yeah.
Because we have different levels of care.
Correct.
There's home hospice, there's inpatient hospice. So inpatient hospice, there's been times where if somebody from here that's on hospice goes to the hospital and the doctor says they have less than 5 days left, and it would be, and it would be uncomfortable for them to try to transport home, then we will admit them in the hospital. We have contracts with the hospital so that we can go and admit you inpatient hospice. You would get all the medications that we give you at home via IV so that you can pass there. Now, if you are unstable, but you have in your glittery book, do not let me die in a hospital, then you better believe I will order transport, get you home, and you may pass as we get in the front door, but if that's where you want to pass, that's where you will pass. Okay? Any other questions? Yes. Oh.
I came down here thinking I had one question.
And it was one I was ready for too.
The one question that you're ready for is for you and for the ARC. The other question that came up on the way is for the ARC.
Okay.
I picked up a used Kleenex from the elevator floor. Why does the ARC not have wastebaskets on the hallways? The question that I had for you and the ARC is, will you support voluntary stopping, drinking, eating, and medications?
Absolutely. If we have a patient that decides they want to stop eating or drinking, then we tell the facility, and the ARC already knows this and they fully support it also. Nobody gets force fed. If they don't want fluids, they're not forced to take fluids. They know what the end result is going to be, and we fully support it. Just as much as I support someone being on hospice that's a diabetic that wants a cupcake. If you want a cupcake, I'll bring you a cupcake. If you want to have a scotch every night, then you have your scotch every night.
Sign me up.
Hospice fully supports whatever you want, no matter what it is. If, you've got cardiac issues and you love your salt, and that doctor said no more salt for you, it's time for Mrs. Dash, Jade will bring you a salt shaker. Okay? If you start to swell because I've allowed you to have so much salt, then we'll take care of that. We'll put you on something to help with the swelling. We deal with the consequences, okay? But we want you to have whatever it is you want. Taylor?
If someone is living alone in their apartment and they don't have the desire to go over to healthcare, I know hospice is available 24/7, but how do we work with private caregivers for non-crisis care assistance?
So we can help with provider services. Provider services are people that come out that you pay hourly. Now, provider services are not covered under hospice. That would be private pay by you or by your family. And I know that the ARC can probably set you up with provider services also. But that provider would go in, say you want them from 8 a.m. to 5 p.m. Then that's what we would get you a provider for. Or Deborah can help you find a provider for. If you decide I need someone around the clock, then they would have, 2 providers come in and do 12-hour shifts, or 4 that do, so many hours. So the provider would do all those things that you can't do for yourself, whether it's cooking, cleaning, laundry, bathing, all of those things. The providers can do those things. The only thing they can't do is medicate you. They can't do the medications, okay? So if someone we normally take care of everyone's med box. A lot of people that aren't in healthcare, because healthcare handles the meds, but if they're in their home, every week when the nurse goes out, she manages your pill box. And then if there's any changes that need to be made week to week, she'll change those and organize the pill box all over again if need be. But the providers can do everything except, go into the fridge and get this medication. Now, if I leave a cup on the nightstand, little med cup, and it's got pills in it, if I say the patient needs to have this at 8 a.m. every morning and this one at 4 p.m. in the afternoon, as long as it's filled in the little cup, they can hand you the cup. They just can't go into a pill box and start picking out medications. Okay, but as long as it's pre-poured, they can give it to you. Now, like I said, we don't start with the heavy stuff right off the bat. So a lot of people get really scared with morphine. Okay? Our morphine is very effective and it works well. It's got a dual purpose for us. It's called Roxanol. It's kind of like a diluted form of morphine, but it's very effective. We give it for pain, obviously, but it works very, very well for shortness of breath. So we do always keep a comfort pack in the home. A comfort pack contains the Roxanol. It comes with like a Tylenol baby dropper, and you get this super teeny tiny 0.25 initially. It goes under the tongue or in the cheek. It absorbs in the mucous membranes of the mouth, so you don't even need to swallow it, and it's very fast acting. So you get morphine in the comfort pack. You also get Ativan, which is for restlessness or anxiety. Comes in handy, okay? Then there's also something for fevers, for constipation. It's like an emergency kit. So if you call me at 3 o'clock in the morning and say, Jade, this is going on, I'm really, really nauseous, or I'm in pain, I'm gonna say, okay, I'm on my way, but while I'm on my way there, I want you to take a Zofran for the nausea and 0.5 of the morphine for your pain, and then I'll be right there. But that is there for those emergency situations. Now, as somebody gets closer to passing, they may need the morphine more or the Ativan more. All of our medications can be turned into a liquid if need be, especially if they can't swallow pills anymore. But as somebody gets closer to passing, they may get those medications more often. And I'll be honest, I've had patients here where the doctor's like, they need that every 30 minutes. And they'll get it every 30 minutes. And I tell you what, they are so comfortable by the time they pass. And sometimes it's the anxiety and restlessness. Okay? I'm getting my steps in. Yes, sir?
Hi, I'm a elder lot year I was in Colorado, and I just want to reinforce some of the things you said today about bringing the family in, making sure they know what you want. The book that you were talking about, as far as having any legal effect, I don't know in Texas if it does. In most states it does not, but the other documents that you should have, including a medical power of attorney, a living will, those documents do have legal effect. And whatever you specify, particularly in your medical power of attorney, as to treatments that you would want or would not want, your agent in that power of attorney is legally obligated to carry out whatever you say. So when you decide on an agent for your medical power of attorney, make sure it's someone who agrees with what you want. I've seen family members who disagree, and I know you have, and you end up potentially in court. You may have to go get a conservator or guardian appointed, and no one wants that. So just make sure all your family members know what you want. Make sure they're all, the same sheet of music, so to speak, so you have no family disputes at the end of your days. That's the last thing you want. You've got too much to deal with otherwise. But everything that you've said about keeping this book, making sure it's consistent. You don't want to say something in your glittery book that is inconsistent with your medical power of attorney or your living will. So consistency is important, picking the right people to make these decisions for you when you're unable to make them, that's very important.
I have a Vow of Life sticker on my door. They will take, I've been assured that the ARC will take that as a do not resuscitate. Am I wrong with that?
It has to be accompanied, it still has, legally, it still has to be accompanied with a completed DNR.
I have a complete one, and I also have it in my policies.
In your advanced directives. Okay, that's good. I always tell people to put their DNRs on the fridge, on the side of the fridge or on the front of the fridge. But as long as you have a DNR, yes.
It's on my door and on my roof.
Yes, yes.
So to add on to that, if a DNR is, I work with Jade, sorry, hi, my name is Taylor. But to add on to that, if you do have a DNR, I know a lot of y'all are still very active, y'all are out and about and in the community. Take a copy and put it in your wallet so that if you have driven down the street to Walmart, if you are down the street at Target, if you're at Chili's, whoever is with you knows they can pull that out of your wallet, Or when EMS comes and looks for identification, if you're by yourself, they'll open your wallet to look for your ID and be able to see that DNR there, because you want your wishes respected here at the ARC, of course, but everywhere that you are. So it doesn't hurt to keep an extra copy on your person when you're not in the building too.
To add on to what you were saying about the medical power of attorney, I fully support that you guys need to find the right medical power of attorney. I'm married and I adore my husband. He's amazing, but he's not my medical power of attorney. The reason I didn't choose my husband is because I worried that he would make a decision based on emotion instead of on what was going on with me. If I can't be up and doing the things that I'm doing now, I don't want to be stuck in a bed, anything like that. My husband would keep me around just because he doesn't want to let me go. He would keep me on a ventilator until the ventilator isn't doing anything for me anymore. So I have several nurses, because during COVID and everything, I worked at Northeast Methodist Hospital. That's where I was stationed. So I have 2 nurses there as my medical power of attorney. And a doctor that is a very dear friend of mine, Dr. Gandhi, he is on my medical power of attorney. So find the right one. Know that it's someone that is going to abide by what you say. I can have I can say I'm a DNI, do not intubate. But if my husband doesn't pull that form out because he chooses not to let me go, he won't go by it. So I made sure everybody has my stuff. There isn't one person in that hospital that you ask that can't say, oh no, Jade doesn't want any of that. Everybody knows. It's funny, during COVID, because of all the death we were surrounded with, all of us started to make those plans. I mean, after I was diagnosed, started to make the plans, but all the other nurses, and they could be nurses that were in their 20s or their 50s, we all did our arrangements because you never knew what was going to happen. So it's good to have those things done ahead of time. But absolutely, talk to your family and make sure everyone's on the same page. Because I guarantee you, there's several in here that if you've got a son and a daughter, they are not seeing eye to eye. One will say, do everything that's possible, and the other will say, that's not what mom wants. Okay? Any other questions?
Is being on a ventilator and being intubated the same thing?
Yes.
Okay.
Yes. It means the machine is breathing for you. Now, if I go into the hospital and your family or your MPOA decide this is not what she wanted, then I would admit you inpatient hospice in the hospital. I would start a morphine drip. People that are intubated most of the time can't communicate. They can't tell us what they're feeling or how they're feeling. So I make sure to cover all my bases as far as comfort. I'll start you on a morphine drip for pain and shortness of breath, because when I extubate you, meaning pull the tube out, I don't want you to feel like you're gasping for air or suffocating. So I'll load you up with the morphine beforehand, the Ativan, anything that's needed to keep you comfortable, and then we'll pull the tube out. Okay? Yes.
The DNR at a 30-year-old is so different than a DNR at a 80-year-old. So I don't know, I hesitate in doing it that way. I mean, I'm there just about, but I'm just thinking about these young people that are looking at what they prefer in writing at this point.
So they have their advanced directives done, not their DNR. So the advanced directives and the DNR are 2 separate forms, okay? The advanced directives talk about your wants, what you want and what you don't want. Now, in there, it can say things like, correct me if I'm wrong, if I can't lead a normal life or if I'm going to be stuck on a machine, then go ahead and let me go. But if there's a chance that I can yes, go ahead and let me go. But if there's a chance that after a week of being intubated that the doctors think I can come out of it, then intubate me. Is that correct?
Yes.
Yes. So you can be more detailed in your plans. Now a DNR is a completely separate form. It says State of Texas DNR, and that, once you bring that out, that's the one that says, nope, don't do anything. That's the one that's solid, that says, if my heart stops, do not touch me. Just let me pass. Okay, so it's two separate things. Anyone else? Yes.
I forgot to mention it earlier. Brought some copies of an article on the business of voluntary stopping feeding and drinking.
Yes, and I put them over there.
As I understand it, you have to have a doctor prescribe hospice, and you have to be within 6 months of passing. That's right.
So yes, we do need an order from the doctor that states that we can evaluate and treat if appropriate, and that the doctor feels that at the time of evaluation that without care you might have 6 months or less. But like I said, although somebody can come on, it doesn't mean necessarily that they're going to pass in 6 months. And it can go either way, honestly. Some patients will die after a couple of weeks, couple of months, couple of years. So every time the doctor recertifies you every 90 days, he'll look at you and say, you know what, she's still declining. It's become slow decline, but she's still declining, so she can stay on service. That's how we keep patients on for so long. If the doctor sees that you truly are declining, they'll keep you on service. But if all of a sudden we show up at your house and someone says, oh, she just went out for a jog and then she's gonna go, to Fredericksburg Wine Festival, then we're like, maybe she needs to come off hospice. So then in that instance, they would graduate off hospice. Graduating from hospice, it happens occasionally, and it's not a bad thing. It just means, well, hey, you're doing way too good if you're at the Fredericksburg Wine Festival to be on hospice. Okay? But there are patients that are on hospice that still go to the grocery store, they still drive, they still do things. So it doesn't mean you need to be bedbound or anything like that. You can still go out walking the dog and still qualify for hospice. Okay?
What's your phone number?
You're welcome. Does anyone else have any questions?
How valid is a DNR? I was in the hospital and I told the doctor that I had a DNR. And he said, I don't recognize the DNR.
That, I don't know what doctor did that. That is a lawsuit waiting to happen. A DNR is extremely valid. They have to abide by your DNR. They can't just, A doctor can't just decide, nope, I'm not gonna recognize your DNR. If you have a DNR, they have to recognize it, correct?
Jay, the only thing I was gonna add to
Yes.
that was that it actually, they have to have it.
They do have to have it in
say-
hand.
You cannot just tell a person, I have a DNR. If, like even in, healthcare, residents come in, patients come in and they say, I have a DNR. Until you produce the actual paper in my hand, your full code, and then I will switch you over to a DNR once I get the paper in my hand.
Now, in the hospital, DNRs are a little different. In a hospital, you would need an in-hospital DNR.
Yes.
That one is literally a signature, one signature. You sign it, the doctor signs it, and that is your in-hospital DNR. And then when you get out, you have your out-of-hospital DNR, okay? Which is the one that, who said they had it, and I told them to put it on the fridge. So if you have a DNR, and you put it on the fridge, that's your out-of-hospital DNR. In the hospital, if you want to be a DNR, you tell them, I want to be a DNR, or make sure your family knows that you do. And it is a signature, just one signature, and then the doctors, and that is your in-hospital DNR, and they cannot do anything about it. Okay? Any other questions?
That was a whole lot of important information about hospice. I hope that we've answered a lot of your questions. They have provided some information over here on this table. There's pamphlets. Jade and Taylor both have business cards for you to take with you. And keep in mind, like Jade said, there are 300 plus hospice companies. She provided a lot of good information about heart-to-heart hospice, but I will say that working in healthcare, we deal with maybe 5-8 different companies regularly. They're basically all the same, but there are a little bit of differences to them. So, and I always recommend that when you are ready to make that decision, when you've decided that you want to talk about hospice, that you talk with maybe 3 or 5 different companies, because you'll get a good sense of some differences that they have between themselves. Some offer, music therapy when they're in the later stages of passing, where some do not offer that. Some of them have really good veteran services, where some of them don't have that. So in healthcare, I try to give you a good variety to choose from. But like Jade mentioned earlier, if you pick a hospice company in healthcare that we don't happen to have a contract with, we are very open and welcoming to a one-time contract for what we need. Like I said, the table has a lot of good information, and if you have any questions, please feel free to call any one of us. We can help you with that. Thank you.